Hello, welcome. My name is Jody Scholes. I'm your instructor for the MBLEx review course. Yes, this is a course designed to focus your attention. This is a time where we come together to study, to prepare for our national exam. Yes, we all are holding the vision. You can see we've got a lovely group here. All are holding the vision of practicing as a licensed massage therapist. It's very exciting to lend our collective energies to this vision because not only are you holding the vision for you, I'm holding the vision for you. And this community is holding the vision for you. Yes, and these classes go down in 3 rounds. So 3 parts to this class today. The first one is going to be a test taking strategy. What we found is that the many students uh, have great knowledge, but maybe get a little thrown off by this, by this style of exam. And so in the first few minutes of class, I give you some test taking strategy. Then we move into our learning. And today we're doing the shoulder girdle, the shoulder joint. Let me tell you, there was some terms that I looked up this week that I was like, what is that again? So the shoulder joint is going to be our learning today. Kinesiology, movement of the shoulder joint. To do the movement, we're going to need to review the muscles, the joints, and to get familiar with what that shoulder joint actually looks like on the inside. And then after we have reviewed that material, we will go into part 3 of our class, which is dissecting questions. Yeah. So we'll dissect some questions based on the information you're about to learn. All right. So that's how this is going to go down today. All right. The first part of class is always a test taking strategy. And I want to share with you, maybe for the first time, but hopefully as a reminder, that the MBLEx is a computer adaptive test. Mhm. We recently had a test taker who said, wow, I answered this question about a joint, and I couldn't remember if it was diarthrotic, amnithotic, synovial, like what type of joint it was. And she said, oddly enough, she goes, I picked one joint, and it's synoarthrotic, I think. And she said the very next question was on the cranium. Well, that's because the computer will adapt. That test is going to adapt to test your knowledge. The question that test taker had been talking about was actually synovial joints, so the freely movable joints, but had gotten sidetracked with these non-movable joints. And so that computer, that test adapted to say, okay, wait a minute, you just picked a cranial joint. Let's ask you a question about the cranial joints. A computer adaptive test does get harder. It can, it adapts. So when you start answering questions correctly, you will get more difficult questions in the same category. And you're like, whoa, 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 wait a minute. That's not really fair, is it? It actually, it works to your advantage. And you're like, how does that work to my advantage? It works to your advantage because your goal is to score 630 points. 630 points total. Every question is worth a little bit different value. When you answer a more difficult question, you earn more points. When you answer an easier question, you earn less points. You've got 100 questions to score 630 points. You do need to be at least borderline in every category. Borderline or good in every category. Yeah. Yeah. This is the nature of the computer adaptive test. Some test takers, some graduates of massage school, some massage grads are like, I think the test got harder. You know, some of the questions did get harder. Yes, that's okay. Breathe. You have the tools to deal with these difficult questions. I'm going to prove it to you later when we go into our learning material and when we dissect our questions. There's going to be a few terms, I promise you, today you've never heard of before. But using the tools that you have to breathe and to pull apart the words, I bet you're going to be able to answer those questions. You can apply those same techniques while taking your national exam. Breathe. Stay present. Pull apart the words. Eliminate the wrong answers. Trust your first answer. Yeah. Cool. I'm being called to share with you a little something extra. I mentioned a test taker gave me some feedback this week. That test taker didn't pass the MBLEx this week. And that's super disappointing, right? You build, 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 you think you're ready, and you get there. And maybe you've experienced this. You got there to the testing center and it didn't work out the way you thought. You failed forward, right? And I wanted to share that with you today because we're here for you. We're here for you as a safe place to land. You may not be ready for class the next day. You may not be ready to start studying right again. But when you are, well, just know if it goes too long, we'll come find you. And it's good to feel all the feels, to just experience whatever it is you're experiencing, the disappointment, the sadness. There's a lovely poem that says that the sea creates a sea cave as it carves away the rock. It hits that rock and it carves it away. It hits that rock and it carves it away. And it creates a nice deep sea cave. And the poem says the water is like the sadness. The sadness flows in, but every time that sadness flows in, it carves out a little bit more of that cave, allowing for a deeper expression of joy. And it's true. We have experiences in our life that maybe are disappointing, but I promise you, it's creating a greater capacity for you to feel joy. That depth of disappointment, that depth of sadness, it expands. It expands your capacity to feel. Yeah. Some of us don't like those big feelings, right? Hey, let's stay safe. Let's stay in our lane. You know what? Let's feel some feels. Because when the day comes and you pass the MBLEx, you pass your national exam, that's even more capacity for joy. Yeah. So let's prepare for that national exam, shall we? By doing a little learning. This is the review course for kinesiology in the shoulder joint. We're not going to waste any time today. The shoulder joint is a ball and socket joint. It's the joint that occurs between what's called the glenoid cavity and the scapula. The glenoid cavity of the scapula and that proximal end, the upper end of the humerus. So the shoulder joint is actually a ball and socket joint. Today we're going to be talking about movement of the shoulder joint, and I'll remind you, we're talking about the shoulder joint, not the shoulder blade, not the scapula. So be careful on your questions that you are identifying what the question is actually asking you. So the shoulder joint is that ball and socket joint. It is one of the most freely movable joints. It's pretty open. In fact, it's way more open than the hip joint. The shoulder girdle connects our upper limb to the axial skeleton. Got the axial and the appendicular skeleton. The shoulder girdle connects the axial skeleton to our upper limb. And oddly enough, the shoulder joint is also the second most common area of pain. It's responsible for about 20% of musculoskeletal complaints, meaning when someone goes to the doctor and they have pain in their body, about 1 out of 5 times it's in the shoulder joint. Yeah, so about 20% of the time. All right. Shoulder joint is comprised of 3 bones, 3 joints, and 3 groups of muscles. And a few other structures too we'll throw in there. But let's take a look at exactly what this is, where it's located. So here's our shoulder joint. We got 3 bones. Got the ball and socket, but we got something else. Take a peek. So the 3 bones are the clavicle, the humerus, and the scapula. Humerus is easy, right? It's like duh. So humerus, long bone of the upper arm. Head of the humerus creates that ball of the ball and socket. However, the structure here is very interesting because that glenoid cavity, another picture here. Look at how the glenoid cavity is created by the clavicle, by the scapula. You can see here, there's a little pear-shaped divot. So glenoid fossa, depression, the glenoid cavity is a hole, right? So here you see that scapula with the depression, and that's where the head of the humerus articulates. Articulates means moves. The articulation is a joint, a movable joint, or the articulation is where they touch. I say where they chat, where they talk. That's where they actually touch, that articulation. And then the third component here is the clavicle. Clavicle adds a little support there to this structure. So in this image above, you'll see that we're looking at the anterior view here. This is the anterior view. Head of the humerus, proximal head. You'll see something, a bony landmark called the greater tuberosity. Here's that scapula. The depression underneath here is called that glenoid fossa. And you'll see also part of the scapula. Follow me. Well, actually, follow me here. See how this part of the scapula, there's a little hook at the top, a little hooky thing? That's your acromion. Yeah. So the clavicular acromion joint, the AC joint, ends up being right here. The AC joint, the acromion clavicular joint. Very good. All right, this just labels this as the glenoid because we need to know what part of it we're talking about. Is it the fossa? But we'll see more about this. These are the three bones that play a role in your shoulder joint: humerus, scapula, clavicle. And before we leave this picture, what a lovely picture of the ribs, eh? Look at how these ribs attach to the sternum, right? Here's the first rib. And look how close that first rib is to the clavicle. We'll learn later on that the pectoralis minor plays a role here in keeping that clavicle separated from the first rib. But I just think this is such a lovely picture. You can see the sternum, the manubrium, the body. Can't quite see the xiphoid, but this is the sternocostal joints, right? So where the sternum hits the ribs. Yeah, lovely. A little bit of anatomy. All right. The three joints. We had three bones. Now we have three joints. So we've got the the acromioclavicular. Now, you may have never heard of these joints before, right? That's okay. Break them apart. Acromio. That should be EO, I think. Acromioclavicular. Break it apart right there in the middle. Can you see how it would be acromion and clavicle? So we talked about the AC joint when we were looking here, this AC joint. These are the three bones. These are the three joints. So the AC joint is a part of the shoulder joint. The sternoclavicular joint. So the sternoclavicular joint part of that dynamic. And of course, the glenohumeral joint. So this glenohumeral joint, the AC joint. We're going to learn about a few other joints today. Yeah. You see here the scapulothoracic joint? We'll come back to that. But these are the three main joints that affect the function of the shoulder joint. The shoulder joint itself is the glenohumeral joint, but AC is also very important. Okay. Here's a closer look at all of the structures that are involved in the shoulder joint, because that glenoid fossa is really open and wide. So that glenoid, that cavity tends to be pretty open. And so there's lots of fibrous attachments that help to keep that humeral head in place. Here's the humeral head. And now we have a few layers on top here. Here's our AC joint, covered by the AC ligament. Clavicle, acromion. Again, clavicle, clavicle, comes out to the acromion. Good. Get another part of the scapula. It's called the coracoid process. That plays a different role. It's where the coracobrachialis attaches. So coracoid process, another bony landmark. but an attachment site for a muscle. More so, we're looking at those three bones, those three joints. All right, nice picture. Now, let's take a look at the muscle groups associated with the shoulder joint. The first one is called the scapulohumeral group, or SITS, our rotator cuff group. We've got the supraspinatus, the infraspinatus, teres minor, and subscapularis. These are our 4 rotator cuff muscles. You will need to memorize these names. You will need to memorize these locations. So the SITS is its acronym: supra, infra, teres, and sub. I believe in this slide group, yeah, I go right on to the next group. Okay, so let's just talk about supraspinatus, infra, teres, and sub. These are all attached around the scapula. Super, it is above the spine of the scapula. Infra, below the spine of the scapula. However, subscapularis, under the scapula. In this posterior view of the scapula, supraspinatus sits above, infraspinatus sits below, teres minor is lateral. Sub is under. It's under the scapula. And even though that sounds cute and that's interesting, you are going to need to commit that to memory. All right. But I mentioned there's 3 muscle groups, and I want to... The scapula, we'll talk about it during the scapulothoracic. Okay. So look at how this is separated to scapulohumeral group. You're not going to hear that, but when you see big, long words, know that you can pull them apart and understand that these are muscles that affect the scapula and the humerus. This is what helps to move the scapula and the humerus. We'll talk more about movement of these muscles in a moment. Let's look at the other 2 groups. We've got an axial scapular group. You're like, oh my gosh, what is that? Well, you know these muscles: the rhomboids, the traps, the serratus, and the levator scapulae. Okay. But if you would have seen the axial scapular group, and you're like, what? These are muscles that help attach the scapula to the trunk. So they help the scapula move around the trunk. So all of these 4 muscles, they are primary movers of the scapula in a particular direction. So I want to just pause there, let you get used to the idea. These are all muscles: the rhomboids, the traps, serratus anterior, and levator scapulae, create movement of the scapula around the axial skeleton, around the trunk. All right, good. Last group, the axial humeral group. These are the muscles that attach the humerus to the axial skeleton. The pectoralis minor and major, and the latissimus dorsi. So the latissimus comes up, grabs a hold of the back of that humerus. And that's why it's responsible for movement of the humerus. Adduction, so depression of the scapulas, adduction of the humerus. All right, we'll get more on that on movement in just a moment. But when you see words like this, be like, what are you talking about? Okay, figure out what they're talking about, right? So axial humeral group. They may throw that at you on your national exam. And you're like, why in the world? I know. It's crazy. But pec minor and major, humerus attached to the humerus. Lats attached to the humerus. All right. Here are these groups. Here are these muscle groups. Today we're talking about movement, so I'm not spending as much time on the anatomy of the muscle. Um, but just again here, see, this is where here's the spine of the scapula. This is the posterior view. Here's that supra. Here's that infra. See how teres is out here on the lateral edge. Here's our lat coming up, sneaking in there, touching on the humerus. Triceps brachii. This is responsible. Triceps are responsible for extension of the elbow. Remember? So elbow extension. Yep. Here's the anterior view of some of those muscle groups. Here's the clavicle. Got the deltoid, pec minor, pec major. See a little peek at serratus here. Good. And when we were talking about the bony landmarks, I mentioned the coracobrachialis. That's because it attaches to the coracoid process up here. So it's actually like if you put your fingers across your clavicle and then just snuck in. So clavicle, coracobrachialis is all the way up here. So we've got the brachialis down here and the brachioradialis, radius, right? Coracobrachialis. Up, I say up because it's up touching the coracoid process. All right. Other structures you might hear about with relating to the shoulder is the bursa. There's a bursa sax. There's a labrum, a nice covering of the head of the humerus, and the joint capsule. These are other terms you might hear around the shoulder joint. And so bursa, let's talk about bursa. Right here is the right? Subscapularis, under the shoulder blade, subacromial bursa. Here's that acromion process. And there's some bursa. They're like little water. Are they water? They're fluid-filled sacs. So we'll say fluid-filled sacs that encapsulate, that are right here. They're there to serve as an extra little cushion for that joint. And you may have heard of a condition, a pathology called bursitis. Well, bursitis, there's bursa all over our body. We're going to look at the bursa of the shoulder right here. So bursitis would be itis, inflammation of the bursa. All right. Lovely picture of the head of the humerus. It looks here and says the articular surface. This is the surface that's covering where it glides against that glenoid cavity. And here is our labrum. Right here. It's cut away a little bit. But that labrum covers as well. Sometimes you'll hear about injuries. I have a little tear in my labrum. That can be surgically repaired, usually from overuse. But a nice look. Here's that deltoid tendon, technically. Good. And there are some things I'm not going over. We do not need to be up to a doctor's speed on these, on some of these terms. I did decide to include the blood supply and the innervation of the shoulder. Okay, because if you see this type of wording, it can blow you out of the water. I doubt you'll see it in your MBLEx. I doubt you'll see it at any national exam. Texas, New York, Canada, who else has one? Hawaii. But just pause if you see these and look for a word you recognize. Boom, humeral. Oh, wait a minute. I recognize humeral. That's part of the humerus. Humeral. Okay, I must be up in the direction of the humerus. Suprascapular vessels. You recognize scapular, subscapular vessels. So blood vessels are arteries, veins, capillaries, all of the vessels, all of the blood vessels. These are the vessels that serve the shoulder, the blood vessels. The nerve supply, axillary, right? Remember the axillary. Musculocutaneous. We'll come back to that one. And subscapular nerve. So you recognize axillary, right? In the region. You recognize subscap in the region. We don't often talk about this musculocutaneous, so I wanted to just define it clearly. It starts C5 through C7. No surprise that the innervation of the shoulder joint is starting in our lower cervicals, right? That's what C5 through 7 means. Cervical vertebrae 5 through 7. It's a terminal branch right out of the lateral cord. And you can see here that this musculocutaneous innervates 3 muscles of the arm. That coracobrachialis, remember, up here, coracoid process, right up here, it's a little one, right? Coracobrachialis, biceps, and the brachialis. And then it's also responsible for the skin of the lateral forearm. So the lateral forearm. So one of the ways I remember this is cutaneous, cutaneous. So we usually don't see too many problems with like the biceps, coracobrachialis. We don't talk a lot about this nerve, but it shows up as an option every now and then. So I want you to know what it does. So here are our 7 movements of the shoulder joint. This is all you need to know about movement. Easy peasy, right? Flexion and extension, abduction, adduction, medial rotation, lateral rotation, and circumduction. I'm going to throw in one more. Horizontal abduction and horizontal adduction. Let's take a look at those movements. So flexion, we've got our arms in anatomical position. I'm laterally facing you because I want you to be able to see flexion of the shoulder joint. Shoulder joint. Does not matter what's happening with the elbow. We are not talking about the elbow. We are talking about the shoulder joint. Please be very careful as you distinguish movement. What joint is actually moving? So flexion and extension. If you've watched any of the videos before, I like to use, you may have heard me talk about the relay race, right? So the images of the relay race, if you've watched a relay race, handing off the baton, flexion, receiving the baton, extension, extension. Yes. Abduction and adduction. Do it with me. Abduction, away from the midline of the body, right? Midline of the body, we move away from the midline of the body in abduction. And then we have adduction, adding to the midline of the body, adduction. Before we leave abduction and adduction, let's move to the horizontal plane because we're doing this in the frontal plane. But how about if we put our arms out here? Go ahead and put your arms out by the side. Horizontal adduction. You'll see this as an option every now and then. It's changing your plane of movement. Frontal, horizontal. Abduction, abduction, horizontal, horizontal abduction, horizontal adduction. They throw that in every now and then. All right. So the important part about the next two images is it does not matter if the elbow is bent or not. We are only concerned with the movement of the humerus. It is going to be easier to see when we bend our elbow. So we're looking to do internal rotation of the head of the humerus. And so if we bend the elbow, it's a little easier to see. As we move that arm across our body, that whole humerus is tracking this is what's happening to the humerus. That bone, you'll see here in the image, is medially rotating. Internally rotating, medially rotating. So that bone is turning in towards the midline of the body. Versus external rotation. External rotation. External rotation can also be called lateral rotation. Good. Now that we're clear about the movements and what those movements look like, how about we talk about what muscles move them? Move us in that direction. Oh, one more. Circumduction. Beautiful picture. I love this one. Just make it a big old hoop to hoop right out here. It's that cone-like movement. So the bottom of the ice cream cone is here, and we trace the top of the ice cream cone with our hand. This is called circumduction. And it's a combination, actually, of a little bit of flexion, a little bit of abduction, a little extension, a little adduction. So it's a circle. Yeah. So, uh, yes. So just to understand that that is the circular movement. Your four muscles of flexion: pec major, anterior delt, coracobrachialis, and little help from the biceps. Pec major and anterior delt. So go ahead and put your arm into flexion if it's safe to do so. Touch the front of your arm. Touch right here. You can feel that delt kicking in. Touch the pec major. As you actually do the movement, that coracobrachialis, also a part of flexion at the shoulder joint. All right, ready? I wanted to keep this super simple. Extension. Posterior delt, teres major. Primary mover, posterior delt. Makes a lot of sense, right? Receiving the baton. One of the things I want to point out as we look at the movement here, in extension, how is pec major involved? Pec major is not involved. We feel pec moving, right? We feel the stretch, right? So be clear about what muscle is contracting and what muscle is extending. The movement is happening from the contracting muscle. Miss Julia, I think I saw you have your hand up, maybe?
Yes. Yes. I just want to ask about their extension muscles. How about their triceps? Is
The
it make
triceps
sense?
are,
Yes, for
so
extensor,
you feel
sure.
those, right? Moving, right?
Mhm.
The triceps extend the the elbow,
Mhm.
and we feel them. They're absolutely helper muscles. However, to move the humerus posteriorly, we have to have two anchor points. One on the humerus and one on the axial skeleton. The tricep itself is responsible for tricep extension, for elbow extension. It's a helper to stabilize the shoulder joint, just like the biceps are a helper to flex the shoulder joint. Okay, I'll go back to those in just a moment. Let me know if there's a follow-up question. Just stick your hand up. All right, more movement. Abduction, that medial deltoid. What do you think for adduction? Yeah, you got it, lats. Pec major stabilizes. And actually, in adduction, the coracobrachialis also helps to stabilize. But the lats are our primary mover of, now, also helps with shoulder depression, right? Shoulder blade, shoulder scapula depression. But adduction, Think about doing that lat pull down machine, right? If you've ever been to the gym and done lat pull downs, you hold a bar and you bring it down and put it back up. Bring it down. What movement are my humorists doing? My humeruses. Yeah. So we think of it in terms of scapula, the latissimus, but primary primary mover of adduction for the humerus. We'll talk about the scapula, in a separate context because we get questions that are about shoulder joint. We get questions about scapula. I'm gonna pause for just a moment here. Let that sink in. You're going to have questions about the shoulder joint, and you're going to have questions about the scapula. They seem like they're the same. They are not. The scapula helps to create the shoulder joint. When you are asked about shoulder joint movement, you are being asked about movement of the humerus. I'm going to let that sink in for a second. When we are being asked about shoulder joint movement, we are being asked about movement of the humerus. Remember when I talked about flexion and extension? And I said flexion, extension, and it didn't matter what the elbow was doing. Likewise, with shoulder joint movement, we only care about the humerus. Okay. Medial rotation of the humerus. Pec major, anterior delt. The lat helps out a little and the teres major helps out a little. They're in there. Pec major, though, again, think about medial rotation. It doesn't matter. So we normally demonstrate like this, right? Medial rotation of the humerus. Pec. Go ahead and bring that forearm across your belly and press. Feel that pec kicking in? Good. External rotation, lateral rotation, infraspinatus. Here's where one of our little rotator cuff muscles comes in. Yeah, yeah. So infraspinatus, posterior delt, and a little bit of teres major. I'm going to look for minor as well. I didn't really talk about minor, and I need to, so I apologize. I'll put it in the description notes. So lateral rotation of the humerus, infraspinatus. Very difficult for many people to do external rotation. Beautiful muscle test. We're going to look at a bunch of muscle tests today to assess the shoulder. And when you have your client just sit down, rest, bend their elbow, and then ask them to bring their arm out as far as is comfortable. Out as far as is comfortable. Many people have restricted external rotation. A lovely place to massage. Infraspinatus. Posterior delt. And go ahead and work those teres. All right, let's talk a little bit about shoulder pain. To identify, to put two and two together, if you will. Great, we've identified the muscles, but what movements, so when the person does this movement and it hurts, which muscle hurts? Okay. We're going to get questions on the MBLEx about what muscle group is involved. Let's take a peek. There's a few different tests. You do not need to know the names of the tests. Just be familiar that they exist. What I prefer is that you understand the movement and the muscle that's being tested. Two types of pain with shoulder pain as we look at it. Uh, True pain is there's a problem with the shoulder. Sometimes they'll call it false, extrinsic, or referred pain. And that is if the pain has its origin someplace else other than the shoulder. For example, if there's a problem with the cervical spine and someone can't, and they have shoulder pain when moving. Uh, Sometimes there's diaphragmatic issues, sometimes there's some type of tumors. Very unusual to have referred or extrinsic pain. 95% of the time, shoulder pain is related to shoulder pain, to the shoulder joint. If you have an extrinsic shoulder pain, they need to be under a doctor's care. They probably already are. This is something we are not diagnosing. In fact, as we look at these tests, these are PT tests. These are orthopedic assessments. These are things that a doctor will do to assess the location of the pain. I'm going to expose you to these tests so you can see when when a client says they are in pain, you can hone in on which muscles are actually involved. Take a peek. First, we're going to do our intake. I'm going to ask about any secondary conditions. Do they have fibro? Have they had an infection? Are they working around toxic materials? Have they ever had any cervical damage? I'm going to do our normal health intake. Once we've realized, okay, there's no secondary conditions, then we can go to the inspection. And these are lovely pictures, I have to say. Very happy with these. Um, so we are going to take a look at the way the person moves, the way they carry themselves, the upper part of their bodies. So in this case, it said they should be undressed. No need. You can actually palpate straight through. For certain conditions, you'll need to get a closer view. But we're going to be looking at the position of the clavicle. We're going to be looking at the position of the scap. We're going to be looking for any scars. We're going to be looking for any asymmetry. Asymmetry means imbalances. We're going to be looking for any drooping, any loss of the contour. Take a pic of this. So asymmetry. Something's going on here, right? Any winging. So winging of the scapulas. Any instability in the serratus or the trap. Super squaring of the shoulders can indicate an anterior dislocation. That's not looking good right there. Now, as we assess, I just caught myself doing it when I was like, ooh, what's going on here? Because I see that. And then you see this little indentation here. Everything looks like it got pushed off to this person's right. Yeah. So in these cases, if you are not sure of what is going on and you have a visual inspection of something of this nature, you need to avoid the area. Unfortunately, if they have not seen a doctor and they don't know what's going on, we are not diagnosing. So it could be a dislocation, it could be something else. So just know what you're seeing. Be like, oh, okay, that's something that a doctor needs to take a look at. No freaking out. No, like, oh my gods. Just be like, okay, that's a little different than normal. That's something that, needs to take a look at. Looks like there might be some lymphatic backup here too. Every now and then there's a cyst that'll grow to this size on a person's back, and it'll start to interrupt the flow of lymph, interrupt the circulation. And it's very easy to have it surgically removed, even a dermatologist. Well, not something that size, but if it was a smaller size, up until about the size of a golf ball, a dermatologist can do it. All right. Another pathology of the shoulder joint is a fracture of the clavicle. You can see here, here's the clavicle, and there's a little disruption. Oopsie. What we'll be able to see is this clavicle has been fractured. It's healed up now. And this is something it's lovely to work below it, but it's going to be very sensitive to work on it. So if you see in your on your MBLEx, GHJ, I threw it in here, glenohumeral joint. Glenohumeral joint. So you're going to place your thumb over the glenohumeral joint. You're going to stand behind the person. You're going to just be palpating, just like this person is doing. Yep. So fingers, thumbs, and you're going to ask your client to move their arm. In this case, they're making a recommendation to rotate the humerus internally and externally. That's a lovely way to start to palpate some structures like the deltoid ligament, and just any pain that's coming from the pec major, pec minor. And if there's pain, here's the funny part about, traditional medicine. Oh, pain in this area is indicative of there's some problem with the shoulder joint. Durr. All right, let's get a little more specific. All right, so palpation of the glenohumeral joint, putting your fingers on the front, doing this through the clothing is 100% fine, and you're going to move them into internal and external rotation, or have them move. But if it's uncomfortable for them, then you can assist them with their movement. What we're seeing here is someone assisting with internal and external rotation. We're also going to be able to palpate some of that bursa. So going to be able to touch right where that bursa lives. Usually it's easier to see with the arm down. And moving them into flexion. Again, I want to mention that we are not diagnosing subacromial bursitis. You are hearing this today because you are gaining a deeper understanding of movement of the shoulder joint, and that the subacromial bursa, remember that layer that's right under, that bursa, those fluid-filled sacs, if they become inflamed from impingement or from overuse, it shows up as shoulder pain. We are not diagnosing that. We are treating the surrounding tissue. Of course, it's contraindicated to work on inflamed tissue. And so assessing what movement creates pain for your client is going to help you work around that area. And now you know that direct manual pressure over the subacromium bursa, and you're going to be just lateral to that acromion, to the AC joint. So you're going to stay out on that deltoid, what's going to feel like on the deltoid. But really, you're being a detective. You're being curious about where this pain is coming from. And it could be some of their bursa, their subacromial bursa. We've got bursa in our hips. We've got bursa in other areas of our body. We're talking today about the shoulder. Bicipital tendon. Beautiful picture of, here's that delta, that bicep, following that bicep. And remember, tendons attach muscles to bones. So the biceps brachii, turns into the bicipital bicep tendon. It's lateral to the subacromial bursa. Find that little divot. There's a little bicipital groove as the client rotates the humerus internal and external rotation. And again, you're palpating, you're curious. You're not going to be able, excuse me, maybe you're able to. I'm not here to have you make a distinction between subacromial bursa and the bicipital tendon, although you'll be able to, because a tendon is round and fat and thick. And when it's inflamed, just this much pressure, your client's going to be like, owie. Yeah. So again, with tendinitis, we work over and below. We don't work on. Achilles tendinitis, we work above, helping to clear the way for that, helping to clear the way for that inflammation to leave. Yeah. So Achilles tendinitis, we want to work the calf. So we can talk about how to work bicipital tendinitis at a different time, but right now we're just assessing it and identifying it. And also knowing it exists, right? Okay, so be curious. Um, People who show up with shoulder pain could have a fracture. They could have arthritis. If they do, or they have an old fracture. Arthritis sounds like grinding or crepitus, and like you'll feel it in the movement. Uh, a painful arc. This is an arc when the arm is abducted. So this is B. So if you have your hand, so a painful arc is when there's pain in this movement. They could have some of that subacromial, they could have bursitis, right? They could have a rotator cuff tear. They could have a dislocation. I hope they don't have either of these because both will require far more extensive treatment than what we're giving them on the day they come for their massage. Okay. This is if you suspect a rotator cuff tear or a dislocation, absolutely got to refer them to a doctor. And for the purposes of the massage today, you're going to avoid the area. Last thing as we wind up the lesson for today, I want to expose you to 7 different tests and their funny names. Uh, we don't see a lot of special named tests on the MBLEx, but I just want to let you know they exist. They're named for the people who like founded them, but just take a look at the movements of them. So here's a bright one, the crossover test. Cross the arm over. Yep. So crossing that arm over forward. So you're bringing that arm up into flexion, bringing it across. So if this produces pain, it could be that AC joint, injury. Again, we're just being detectives here. All right, Apley's. So this is called the scratch test or Apley's scratch test. This is basically to see, range of motion on both sides. You'll find that many clients have a restricted range of motion left to right. But basically go ahead and try and scratch your back and then go ahead and put that back of the hand, the dorsal surface of the hand on the spine and just look at their range. Look at their range of motion. This is unassisted. The scratch test. This, with restriction here, you could be looking at rotator cuff issues or adhesive capsulitis, frozen shoulder. We're going to say another word about frozen shoulder in a minute. Knee impingement. All right, this is an assisted test. You're going to go ahead and have them. First, they go ahead and have the client turn into internal rotation and then bring their arm up. So you can do this with a neutral hand, with internal rotation and external rotation, just to see if there's any discomfort amongst flexion. So neutral, internal rotation, external rotation. And this can also indicate a rotator cuff issue or some shoulder impingement issues, like the name of the test. The Hawkins Kennedy. Yeah, that's what no, okay, yeah. So this is the other impingement test. So you're going to have that a little bit different. Client's going to flex the shoulder and turn the elbow, and then we're going to just turn it in. This is also a rotator cuff test. Good. The empty can test. It could also be the empty cup test. The client brings their arm to 90 degrees and you ask them to act like they're pouring out a cup of coffee or emptying out a can. Reminder, no diagnosing, only being curious, right? So we're definitely going to need to work on rotator cuffs if there's any restricted range of movement or if they need help with this movement. The speeds test. So this is basically a resisted range of motion, forward flexion, and we're going to push down. Forward flexion, push down. So when we ask that client to go ahead and resist pushing down, if there's pain, it usually shows up in that bicipital tendon. Right there, right? Suggests bicipital tendinitis. But again, assessment tools. I want to increase your curiosity. Yeah. To figure out what's going on with the shoulder. All right, last one, the Dugas test. Uh, and this is just a version of the crossover test. Uh, but you go ahead and reach across the body and you can help them, with that. And then you can give a little press down. That is healthy range of motion shoulder movement. And again, you don't need to know the names of these tests, just that they exist. And with their movement, we're testing different parts of the shoulder's range of motion and different muscles within the shoulder joint that surround the shoulder joint. And when a client presents and they say, oh, I've got rotate, my doctor tells me I've got adhesive capsulitis, I've got impingement syndrome, all of them are going to have pain. Some is going to be radiating. The bicipital tendinitis will radiate a little, but this will be the affected range of motion. And so we're looking to improve that range of motion. Final thought before we move into dissecting some questions. A pathology of the shoulder that I'd like you to be familiar with is adhesive capsulitis, frozen shoulder syndrome. It kind of creeps up on people. Usually it's very gradual. Like they start to go to be able to reach for something and it's like, oh, wait a minute. Ow, that hurt. So they stop reaching. So with their lack of movement, the adhesive, sticky, that frozenness becomes worse. This may also follow a primary condition like bursitis or tendonitis, because the client stops moving their shoulder. They then get adhesive capsulitis. Look at the name here, capsule, right? Sticky capsule, adhesive capsulitis, adhesive. Do you ever use adhesive tape? When you're wrapping Christmas presents, you might. Yes, adhesive, sticky tape. Adhesive capsulitis, sticky, resi restricted range of motion. You will not see frozen shoulder on your national exam. You will see the term adhesive capsulitis. What causes it? They actually don't know what causes it. We know that lack of movement actually makes it worse. So could be a rotator cuff tear, could be bursitis, could be prolonged immobilization. Um, Certain medical conditions does happen, like with diabetes, with Parkinson's. They tend to get a little bit more um, accounts of this. But it's most common after, between 40 and 60. But do note that it is important to know we don't actually know what causes it. Yeah. So, and what actually is it? It's a thickening of the capsule. So there's inflammation in the capsule, there's fibrosis in the capsule. It gets very sticky in that glenoid fossa. Um, and just airs the labrum sometimes is involved. Um, and so it's sore, it's pins and needles, and it's not flexible. And the treatment is PT. Well, let me give you more characteristics. Night pain, often frozen shoulder interrupts sleep. It's tender when you touch it, but both active and passive. So helped. So whether that client is moving their own arm or you are moving their arm, there is pain present. And the treatments typically for frozen shoulder are PT, massage therapy. Doctors will want to inject steroids or, excuse me, non-steroidal anti-inflammatory drugs. So glucocorticoids. They'll want to do an injection, basically. Uh, Sometimes they'll want to do a contrast uh, to see where those adhesions are. And unfortunately, some of my clients have had such bad frozen shoulder that they've actually undergone anesthesia. They go into surgery, they put them under anesthesia, and the doctor actually manually rotates whatever is stuck. Very uncomfortable, often very sore afterwards. Not really, I don't know, 50-50 on that one, but just seems like a lot to put somebody under anesthesia and then forcibly like wrench their arm. So, but that's sometimes what happens. One client had rotator cuff surgery and then had frozen shoulder, and it was a result of scar tissue. So her forced manipulation actually ended up working out fine. Wasn't comfortable, but it ended up restoring her movement in the shoulder. All right. When someone has frozen shoulder, these are the exercises they're given. Just wanted to make note of that. You may see them in the future. We got the little itsy bitsy spider going up the wall. Some classic ones, some pendulum exercises where someone holds a weight and they do circumduction. Yeah, very classic stretches. If you're not familiar with these, eventually get familiar with them. They're lovely to have on hand. Um, to recommend to your clients who maybe don't have frozen shoulder, but who have restricted range of motion. Lovely doorway stretch here for the pectoralis. Yeah, very straightforward. So, in wrapping up, all almost all pathologies of the shoulder start with pain. Um, it's important for you to do a verbal assessment, health history, look at their health history form, of course, but then also palpate. Get right on in there. Someone's got shoulder pain, you're like, let me at it. Let me see where it is. We are not diagnosing. If the pain is persistent over 4 weeks, then a second opinion is needed by a doctor to confirm an accurate diagnosis. DX means diagnosis. And you can rule out major issues with the shoulder if your client can simply raise both arms overhead, bringing those two palms together. That means it's safe to treat. We just need to be careful on what we treat. Again, no diagnosing. Yay! Time to switch gears and dissect some questions. Ready? Let's do a body check. How you feeling? How you doing? Let's do it. Oh, reminder on directions. Please go ahead and put your answer into the chat box. And I just put the little hello in here. Oh, before we dissect questions, we have a question, frozen shoulder. Where can cupping be placed? If so, is cupping, if you are trained in cupping, cupping is a lovely treatment for frozen shoulder. Um, the classically best treatment is using a plunger method. Think about plungering your toilet, right? You're going to plunger the humerus into the glenoid cavity gently, doing a little bit of the push and then the pull. Cupping is also lovely for that because cupping pulls up versus presses down, often releasing a lot of pressure. And so in moving into dissecting the questions, if you would go ahead and put your answers into the chat, wait until I say 3, 2, 1, go, and then you can hit enter. I like everyone to have ample time, up to 70 seconds, to read the question and answer the question. So 70 seconds, yeah, that's what you have as far as your MBLEx is concerned. You have about an average of 70 seconds. So I'm going to time us. We won't be taking 70 seconds today, but we will be taking about 15. So, all right. First question. Your client reports shoulder pain. What can you do to diagnose the pain? A. Use one of the many palpation and range of motion tests. B. Use only assisted range of motion tests as they are in pain. C. Refer to a doctor. You can't do the massage. D. We can assess the condition. We can't diagnose. Your client reports shoulder pain. What can you do to diagnose the pain? A. Use one of the many palpation and range of motion tests. B. Use only assisted range of motion tests as they're in pain. C. Refer them to a doctor. You can't do the massage. D. We can assess the condition. We can't diagnose. Let's rule out one wrong answer. You don't need to refer them to a doctor yet. We have not determined whether or not we can do the massage from this amount of information. So that is a safe answer, but we don't know what kind of shoulder pain they're in. So your client comes in with shoulder pain, you're just going to send them to a doctor? Yeah, no, no. All right. Your client reports shoulder pain. What can you do to diagnose? A, use one of the many palpation and range of motion tests. Use only assisted range of motion as they're in pain. Or D, we can assess the condition, we can't diagnose. 3, 2, 1, go. Ooh, everybody got an answer. Ooh. All right, let's see, let's see. Lily nailed it. Let's see. Lily, yes. Aditya, yes. Shauna, yes. Lisa, yes. Rachel, good. Natalie, good. Diane, good. Meg, yes. Maria, yes. Miss V, yes. Uh-huh, uh-huh, uh-huh. Brienne nailed it. Good. Best answer? We can assess the condition, we can't diagnose. Be very careful. The MBLEx and your state exam and your national exam will ask you tricky questions. What can you do to diagnose the pain? You cannot diagnose the pain. You can assess the condition. So good job for those of you who made that distinction. Yay! Next question. The shoulder has 3 joints. What are they? Before you came to this class, I don't know if you knew this. All right. The shoulder has 3 joints. What are they? A, the acromioclavicular, sternoclavicular, glenohumeral. B, acromioclavicular, sternocostal, humeroulnar. C, sternocostal, glenohumeral, costovertebral. D, glenohumeral, sternoclavicular, radioulnar. Can you eliminate like all of these words, right? Oh, yeah, my head is swimming. I don't know, Jody. Pause, please. You can eliminate 2 answers right now. Remember, pull the word apart, see where we are in the body. Do the shoulder joint Macarena. Yeah. Okay. Okay, let's see. Acromioclavicular. Right? Da, da, da. Let's get rid of one wrong answer, shall we? So it's 3 joints, 1 wrong answer. Letter C is not the correct answer. Look here what got thrown in. Sternocostal, costovertebral. Where are those joints? Durr? Sternocostal. That's actually your rib. Costovertebral is the rib head in the back. So costo, where that rib hits the vertebrae. Costovertebral. That's not the shoulder. All right. The shoulder has 3 joints. What are they? 3, 2, 1, go. Ooh, we have a lot of answers. Is it that obvious? All right, where are we? Okay. So let's see. Lek nailed this one. Brenda, you got it. Jennifer, yes. Julia, yes. Rachel, yes. Lisa, yes. Brienne, you got it. Lily, you got it. Shauna nailed it. Patithia, yes. Diane, good. Natalie, yes. Uh, 82, 8907. Boom. Yeah. That might be Lance. Hi, Ms. V, you got it. Tristan, nailed it. Maria, good. Meg, good. Brenda got it. Jennifer got it. Excellent, you guys. I'm so happy. Best answer. Hey. Yes. Yes, yes, yes. Look at you. Look at you knowing your shoulder joints. I am so happy for you. Because look here. Humeral ulnar. Uh. Radio ulnar. Uh. Nailed it. Good job. All right. Next question. Ooh. What is the most commonly injured rotator cuff? I did not tell you. Sorry. Mm, Excuse me. What is the most commonly injured rotator cuff? Guess it's gonna be a good guess. Sorry, I forgot to tell you. A. Subscapularis. B. Infraspinatus. C. Supraspinatus. D. Teres minor. We are going to eliminate one wrong answer. We'll just go ahead and do it. It's not the subscapularis, although you might think so. It's second most common. What is the most commonly injured rotator cuff? Infra, supra, or teres? Three, two, one, go. All right. You get double the points if you get this right. Although I'm guessing, oh, very good. Let's see. Shauna got it. Lily got it. Lisa got it. Good, Lance, yes. Tristan, yes. Miss V, yes. Meg, yes. Diane, good. Maria, yes. Maria, maybe I did mention what that it was the most common. Good. Patitia, yes. Yes. Julia, yes. Excellent work, you guys. Most commonly injured rotator cuff is supraspinatus. It's involved in that overhead throwing and that those overhead movements. And so most commonly is supra. All right, here we go. You ready? Gonna go on a little ride with me. Where is the supraspinatus located? Under the scap? Below this, so A, under the scap. B, below the spine of the scap. C, above the spine of the scap. D, on the lateral border of the scap. A, B, C, and D are all locations of rotator cuff muscles. Where is the supraspinatus located? We're going to get rid of one wrong answer. It's not under the scap. Wink, 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 wink. All right. Where is the supra located? Where's the supraspinatus rotator cuff muscle located? B, below the spine. C, above the spine. D, on the lateral border of the scap. 3, 2, 1, go. no. Scaredy cats. Come on, come on, come on, come on, come on, push enter. Trust your first instinct. Trust your first instinct. I hear some of you second guessing. Let me go to the start. There we go. Ms. V, you got it. Yes. Excellent. Oops, whoops, that was the other answer. That was the other question, Miss V. I haven't seen your answer yet. Sorry. Ms. Meg. Yes. Diane. Yes. Maria. Brienne. And Patithia. Yes. Julia. Yes. Rachel. You nailed it. Diane. You got it. Maria. Yes. Brienne. Good. With Miss V, where are you? Lance, you're in. Lily, yes. Rachel, yes. Tristan, good. Congratulations. Yes, Lisa J, you got it. Ms. V, there you are. Good. And Petithia, uh-huh, uh-huh. Brenda, good. Julia, nailed it. Meg, good. Jennifer, mm-hmm. Black, there you are. Yes. Good, good, good. All right. Best answer. Above the spine of the scap. Supraspinatus, right? Supra. Above. Super, your supervisor is above in the org chart. Yes. So above the spine of the scapula. Yay, yay, yay. Hang in there. Hang in there with me. We're almost done. Marathon day today. What is the primary movement of the supraspinatus? Oh, you lucked out. I already eliminated one wrong answer for you. This is a long, tough question. All right. The primary movement of the supraspinatus. Look at each of these answers. It is written in the affirmative, and it's meant to be an example of how you may want to frame answers. So, what is the primary movement of the supraspinatus? A. The primary action of the supraspinatus is to abduct the shoulder and stabilize the shoulder joint. Ignore that under the scapula thing. B, the primary action of the supraspinatus muscle is to adduct the shoulder and stabilize the shoulder joint. C, we're going to skip that one because I eliminated it for you. The primary action of the supraspinatus is not to flex the shoulder. D, the primary action of the supraspinatus is to horizontally adduct the shoulder and stabilize the shoulder joint. Okay, so this is written in an affirmative way. The primary action of the supra is to abduct the shoulder joint. The primary action of the supra is to adduct the shoulder joint. The primary action of the supra is to horizontally adduct the shoulder. All right, you can eliminate one more. Here we go. 3, 2, 1, go. Okay. Got some brave souls answering the question out there. Let's see. Ooh. Tristan, yes. Jessica, yes. Julia, Meg, Diane, Shauna, Lance, Maria, Brienne, Aditya, yes. Lek, yes. Brenda, good. Rachel, good. Yes. Best answer. The primary action of the supra is to abduct and stabilize the shoulder joint. I ignore that under the scapula thing. I think it was a misprint. Good job. Good job. Great work today. Oh my goodness. You're going crazy. You just spent over 90 minutes with me. Goodness gracious. How you feeling? Just do a body check. Give yourself a little wiggle. Oh, yeah. Woo. How's that feeling? This is a measure of your test taking stamina, right? Gonna wrap up this work on the shoulder joint. Thanks so much for being here. I'm going to stay on with this group, answer their specific questions. I wanted to just say thank you for making time to study for your national exam, for the MBLEx, for New York, for Canada, for Texas, for Hawaii. I'm so excited for you to give your gift to the world. It really, we need you. We need you. So, my name again is Jody Scholes. I'm your instructor for the MBLEx review course. Signing off for this week, and we'll see you again soon.